This is Dr. Caudle Miller, and today we're going to talk about headaches. And this is the first of a series on migraine and tension headaches. So, when you come to a doctor's office like mine, I have two goals. Number one, make a diagnosis what type of headache it is, and number two, make a diagnosis what type of medicine to give you, whether it's symptomatic treatment, prophylactic treatment, or both. So, it starts with making a diagnosis. In general, there are two types of headaches, migraine and tension headaches, and we can go through all the different classifications of headaches and all the subsets of this, but we're going to think of this sort of simply, migraine and tension headaches. Migraine headaches were described in writing the first time in like 440 BC by a medieval king. He had terrible headaches, and he described seeing these bright lights, and he described them like torches on the top of a medieval castle at night. And they call that fortification specter. He would see this fortification specter first, and then he would get a migraine. He was so sick, nausea, vomiting, photophobia, just sick as a dog. They tried everything. They put rocks on him, they bled him, they leeched him. He actually died from being bled to death. He actually thought that bleeding helped, and so they actually bled him to death. These are migraines with R's. They're rare. They say they're about 10% of migraines, but it's really much less than that. Migraine without R is much more common. They don't have the R, so there's no fortification specter or any other form of aura. And it's the most common form of headache. Cluster migraines are migraines that occur in clusters. I had a patient had them at 3 o'clock every day for 2 weeks, and he'd come back every 1 or 2 years with a cluster that lasted a couple of weeks, and they could be horrible. Ice pick headaches, stabbing, almost like an ice pick, sticking you in the head a brief second. It'd be unbearable if it lasts more than a brief second. Also called benign paroxysmal hemicrania, used for indomethacin. So how do we go about trying to diagnose what type of headache they have? It starts with a good history. The age of onset. When did they begin having headaches? Most migraines begin when someone's young. Are they focal or generalized? Like a migraine, often a temporal throbbing, pounding pain. A tension headache would be like a generalized pressure-like pain, like a vice. Is there an aura or no aura? If they have an aura, it's almost always a migraine. What is the character? Is it throbbing, pounding pain? Is it pressure-like pain? Is their head in a vice? They're 24 hours a day, 7 days a week. Those are not migraines. Those are tension headaches. So how frequent are they? My general rule, 2 or 3 days a month ruined by migraines, they go on preventive medication. Do they have nausea? Do they have vomiting? Rare, which is plain tension headaches, common with migraine. Photophobia, aversion to sound, common with migraine. Phonophobia. Photophobia is aversion to light. Phonophobia is aversion to sound. Are they worse with movement? Migraine headaches usually worse with movement. Are there any focal neurological symptoms associated with them? And then what is their treatment history? What medicines have they taken and failed? And what doctors have treated them? Have they had a CT or MRI? So when I start using the medicines, we think about the 4 pathophysiological mechanisms of a migraine. You get a vascular, a biochemical, and then you get an electrical. And then we have this trigeminal system activation that occurs. And so we're going to talk over the next, 20 or 30 videos on the different drugs we use in this class. So when you have a migraine, you get a constriction of the blood vessel followed by a dilatation of the blood vessel, followed by a release of chemicals. And then the release of chemicals causes a tsunami of electricity. So constriction, dilatation, release of chemicals, a tsunami of electricity across the brain. And then you get this trigeminal system activation. Small proteins, the CGRP, that are prevalent in the neck and the head are very involved in pain perception, and their levels are greatly increased during migraine. So we use drugs to help decrease those levels. So the classes of drugs that we use based on whether we think what of these mechanisms would be the one we should treat in that particular patient. For example, the vascular mechanism. These are usually blood pressure medications. Beta blockers like Inderal. So a young woman who's in childbearing years, throbbing, pounding migraines, Inderal is a great choice. Very safe in pregnancy, we think. It's, if they're hypertensive, you can switch to a beta blocker and may kill 2 birds with 1 stone. The negatives about beta blockers, they can take several months to work, 3 to 6 months every time you change the dose, and it can take a while to build it up, but you can take them the rest of your life, and they're very safe. Can't use them in asthma because they can precipitate an asthmatic attack. Can't use them in diabetics on insulin because it can mask their low blood sugar. So their blood sugar can drop. They won't know it till they're unconscious. So don't use it if they have heart disease or bradycardia. If we're going to use Inderal with someone with heart disease, always call and talk to their cardiologist. One thing Inderal can do is sort of drag you down. So a third quarter soccer athlete, fourth quarter basketball player, they may not like Inderal. Famous story about the Syracuse basketball player who was taking Inderal for, either SVT or atrial fib, and he just was scoring 30 points a game, and it was dragging him down, so he stopped taking it and died of an arrhythmia on the basketball court. It's interesting, the ladies' golf tour, they were all taking beta blockers, healthy athletes, because they weren't getting the yips when they putted. They were, weren't as anxious. And we use Inderal for, panic attacks and anxiety. And then a couple of men started taking it. Then a famous man started taking it, and they just banned it. But the rumor was they were concerned that the women were going to putt better than the men, so they banned it, even though it's not really a performance-enhancing drug. Love Inderal in young people. Just go slow. Verapamil is an next blood pressure medicine we use. It'd be very common to use, say, for example, a man with hypertension just switches blood pressure medicine over to verapamil and may prevent the headache. And Atacand, which is an ARB, is another one. Another one that's worth a try. Someone who's hypertensive is a very good choice for hypertension first line. So if they're hypertensive and have migraine, just switch them over to Atacand. The second pathophysiological mechanism is the biochemical, the release of chemicals. And we'll talk about this in more detail in its own separate video, but the tricyclic antidepressants, we've been using Elavil for 50 years. Pamelor is my favorite. My second favorite is Cymbalta. Cymbalta increases, serotonin and norepinephrine. It's a class of drugs. I think there'll be more drugs in this class and very good for migraine and tension headache prevention. And you got Effexor. Effexor works great, particularly in young people that are anxious. We may use Effexor. And we'll talk about this in the biochemical video. Wellbutrin's another option. It's worth trying. Just be careful. If they have epilepsy or have a seizure on it, they can't take Wellbutrin. The electrical, the third mechanism, this is our anticonvulsants. It's a tsunami of electricity. Topamax, Keppra, Depakote, Vimpat, Zonogram, Gabapentin, Lyrica, they all are drugs that we can use for headache. We like Topamax and Keppra the best, and we'll talk about these in their individual videos. The trigeminal system activation, the two different classes of these, the monoclonal antibodies and the GPANTs. When these monoclonal antibody drugs came out, they block CGRP. It's just been a miracle. These are incredible. You take them once a month, and the use as a migraine prevention, almost like a birth control shot for migraine. Amivig was the first one that came out, and then Emgality, and both of them just work great. Ajovy, Vyepti is the newest one that's used for IV. We'll talk about all these in a separate video. And then you got the GPANTs, we first started using Nurtec. They're not monoclonal antibodies. They work in a different mechanism, so you can use them if the monoclonals haven't helped. Nurtec first came out in pills, and now it has a preventive form too that you take every other day. And Culepi is 60 milligrams a day. So all these different choices, that we have, and we're going to talk about these in separate videos for each of these four pathophysiological mechanisms, and then talk about how we're going to treat migraine. So this is sort of the first video on our headache series. I think if you watch this video and then watch, the vascular hypothesis and the electrical, and then the biochemical, and then the trigeminal vascular activation, watch those next, and then start, if you interested in the individual drugs, you can watch those. So this is Dr. Caudle Miller. Like my channel, subscribe, make some comments. More later.